2016 was a busy year. Let's take a look at some of the major events that impacted the fields of emergency medicine. And so let's look locally at Tampa at just how much change we've gone through. Our own hospital started the year out really optimistic, I think, with the buzz about the Brandon Healthplex, which is a freestanding ED as well as outpatient surgery and some other outpatient facilities located in a really large area of town just to the east of the city of Tampa in a suburb called Brandon. This is an area that's super busy. There's a top flight golf right across the street. The former CEO of our hospital had remarked something, in the millions of people driving by this place, on a pretty routine basis. So this is a busy part of town and a busy area. And I think this is going to be a busy place when it does open in 2017. That's how we started the year, and that's what most of the year was all about at Tampa General, was the upcoming Healthplex. But at the same time, echoing how much change we are undergoing, we also lost a COO and then later lost a CEO, really the CEO who's the architect of this change and of this Healthplex itself. So we enter 2017 without a formal COO. The idea of restructuring that position into a position that oversees the healthcare system was on the table by the former CEO. However, we also enter 2017 also now without a formal CEO. We do have an interim CEO in place, but right now Mr. Burkhart is no longer the CEO of Tampa General. I think these changes we saw in just 1 year at Tampa General probably echo what you've seen nationally and what's going on across the landscape in emergency medicine. And I think what you're going to see throughout this presentation, that this is a time of drastic change. One of the things that I believe drove some of the changes we saw in leadership, not only at our hospital, but also likely other hospitals as well. And I think some of the changes that are occurring both on our clinical practice and demands on our clinical practice that are not solely based just in evidence-based medicine are the demands of quality and transparency. Some of those completely appropriate demands. Some of these initiatives and metrics and processes and process improvement pieces that we are all having the pressure of facing now are 100% things that healthcare needed and things that were lacking in medicine. A number of them are also things that are very difficult to meet and things that maybe do not recognize all the pressures we actually face in clinical medicine or in our patient populations. I'm not sure how many social determinants of healthcare are taken into account when you look at a hospital rating. I don't know if people think about what it looks like to work a night shift in an ER and take care of violent drunk people who are desperate with nowhere else to go. So these are difficult quality metrics that are reported nationally. You can go on hospitalcompare.gov, look up your local hospital, and look up your zip code, compare hospitals across the board without the nuanced knowledge of knowing what a private hospital versus a public hospital, a hospital that's teaching, hospital that it sits in the middle of a downtown urban area and sees a lot of indigent patients. Without that nuanced understanding of those different patient populations, I think some of these reports would look pretty bad if you were in the general public. If you were trying to decide where to have a surgery, obviously the pricing is very difficult to get at for patients. Even if we report pricing, insurance is vary, Medicare, Medicaid, and private insurance, no funding. So I think that's a hard piece for consumers to arm themselves with. But if I go on a website and I look at infection rates or I look at the number of stars that I got, that seems like a end user metric that is a little bit more translatable for if without understanding that background of what these subpopulations look like. So unfortunately, that's where we're at right now. That these stars, you see the stars over on the side of the screen there, these stars are reported right now on hospitalcompare.gov, and really there is no stratification for what these hospitals look like. That's the world we live in right now, for better or worse. I think this probably drove some leadership change at our hospital, and it is likely either driving leadership change at your hospital or driving what the leaders at your hospital are doing with their time and what your meetings look like. If you're going to meetings with hospital leadership or you're sitting on committees, I spend a lot of time right now on a SEP1, which is a Sepsis Compliance Bundle Committee, as well as a number of other committees that really think as a system about how to meet some of these important metrics. I will say, I think the positive of this is that the responsibility of the hospital to meet this means that my patient has become our patient essentially across the board, and the excuse for variability that leads to poor care is really not tolerated anymore, no matter how much money an individual provider might say bring into a hospital, because overall the hits you're going to take in quality metric performance are going to be greater than what some private surgeon or private cardiologist might bring in from elective cases, even though they may do things in a maybe less than evidence-based way, or maybe outside the variation curve we see for the other providers. So I think that's probably the one promising piece, is that we've started thinking more like a system. And I think also, if you're an emergency medicine provider, this is a critical time to sit at the table. I think the table is active right now. I think that some people do not want a seat at the table because they are sick of this stuff, and I think they're getting burned out. And I think for those of us who do decide to take a seat in emergency medicine, I think there is a lot of influence that we can have in terms of how this goes in the future, or at least a lot of ability to at least feel as though we have some control of our destiny. Whether we do or not, it's some of these are so nationally based, and the cart is way before the horse. So it's hard to say how much influence we have overall, but at least in terms of how your hospital responds to these metrics in a way that doesn't neglect or leave out your ED, I think there's a real place right now for you at the table for that. And it's not neglect who the ED provider is and how important they are to, say, the sepsis patient who enters the ED. Is the vast majority of the patients who are going to enter the hospital with sepsis. And so if we fail there, we probably will fail across the board. So we can't ignore that patient population or us as providers anymore. So get involved. I think as we see some of these slides on burnout that are coming up, one of the things you see over and over again is that providers who feel as though they have some control of their destiny, providers who feel as though they have an ability to dictate what their future is going to look like and have a seat at that table, are the ones who feel less burned out. Who are the ones who feel that there's something bigger than just themselves. Not all is bad. Overall, there were some gains in income compared to 2014. So emergency medicine physicians still do pretty well for 3 years of training, kind of sitting right in the middle of the pack here. Pediatrics really low there at the bottom, given the poor payer mix, reimbursement mix, and then the orthopods still raking it in. So the super smart carpenters, if you will, still doing pretty well, as well as the cardiologists and other subspecialists. So I think overall, though, remuneration for what we do is fairly good. Of course, it could be better, and I would love if somebody wants to pay off my student loans. But we sit there at the middle of the pack, and this is not without some challenges. Female physicians still tend to make a significant less amount than male physicians. There's a myriad of reasons for that. I'm not going to go into the actual reasons. Just kind of pointing that out as something that does exist, that we recognize that females do make less than males still in this discipline, again, for a number of reasons. I was at one point told that the reason you see burnout in emergency medicine is because you have non-board certified providers who are practicing emergency medicine. And as the system changed over the last, from 1975, say, until 1995 or 2005, as that system changed, it was really hard for those folks who maybe really weren't equipped with the skill set needed to do emergency medicine, or the mindset needed to do emergency medicine. It's really hard for those folks to keep up and to keep pace with what emergency medicine had become, what it was looking like, and it was those folks who were really the ones who were getting burned out. That's been over a decade ago that I was, considering going into emergency medicine, and started my residency, and was told that by my mentors. And there was some data for that as well. I think, unfortunately, now, over a decade later, that's a hard argument to make. I think it's pretty clear that across the board, physicians in general have burnout, and I think it's pretty clear that across the board, ED physicians have high rates of burnout compared to other groups. I think there's some coping strategies here, and I also think there is some responsibility on our part, and there's some, you know, pressures from other sources that are leading to this. I can't do anything about those, but we can do something about us, and we can do something about who I am and who you are. You can do something about as well. So control the things you can, right? Well, I think the things you can do that there's good evidence for, again, is being a part of something that's bigger than you, whatever it is. Whether it's having a fellowship training in something, so some days you're doing some EMS work or some sports medicine work or some talks work, or if it's maybe the military or reserves, or maybe it's mission trips, or for me it's research and academics and teaching, plus a little bit of sports medicine, plus some from all these little things on the side that I think make it exciting for me to go to a clinical shift. And I think we have to look for ways to make ourselves excited. Otherwise, I think that's where we're heading, is towards burnout. And I think you have to find out what that number of hours is for you a week, and what that number of hours is for you over the course of your career, and how many patients it's likely you're going to see over the course of a career, because there's probably a finite number until you start screaming at them or until you start getting frustrated with them and can't do it anymore. So whatever that number is, you got to figure it out. And whatever that thing is that you're going to do that's bigger than you, I think you got to figure out. Because otherwise, I don't think we can all just go to work every day and just do a shift and go home. So whether it's hospital committees or something even bigger than the hospital, I think we got to figure that thing out. I don't think it is realistic to think of balance and not get burned out. Meaning, you're never going to have all four burners burning at the same intensity. You're going to have to emphasize different burners at different times. I think the key is to come back to the burner when you need to, right? Leave one thing simmering, leave one thing boiling, move it around when you have to. This is not my idea. I certainly have my own challenges in life, but this is some good work that's out there that you can read about. It's called the burner theory for balance and to avoid burnout. So I think there's some good stuff there. But again, if you look at the people who've been doing this for 25, 30, 35 years and who are happy doing it, my mentors who are happy doing it, they're all people who do something else other than just go to a shift each day. I think probably the biggest story, especially here in Florida, and I think nationwide in emergency medicine, for 2016, really has to be the Pulse nightclub shooting. It just brings up so many important issues for emergency medicine physicians. It exposes us, I think, for how unprepared most of us likely are for a mass casualty event. Orlando did an extraordinary job, and they had actually done training and done recent training on how to handle this. And of course, it was still overwhelming. Right now, I can't say 100% for sure. We have a great plan that we've simmed and practiced and all know really well. Our director of security just retired after 30 years, so our hospital's looking for somebody new for that. So, I don't know where we stand with how great of a job we would do. We do a great job, I think, as a trauma team every day, and certainly we have multiple incidents at a time. But to see this kind of response and this relationship with the trauma surgeons and between the ED docs and the trauma surgeons and the nurses and everybody kind of worked together was pretty extraordinary. So I had a chance to both have this department come and visit our group here at USF, TGH, and then also see these guys speak nationally at ACEP, and it's pretty incredible what they did. Not all bad news again. Overall, over the last 15, 20 years or so, death rates continue to decline in the emergency department, probably more so than you'd expect just based on general declines in mortality in general of these healthcare events. I think some of that might be due to keeping people out of the ED at the end of life for home hospice, but maybe some of it's due to having more of us being board certified and being at more hospitals than you had in 1997. So not all bad. We've done some good stuff. Not specifically emergency medicine, unless you're in Tampa or unless you're in Florida, like we are. But Zika was all over the place in 2016, and I think one of the ways it really summarized the whole Zika thing the best. Right, Brazil was the epicenter of Zika. The Olympics were in Brazil. 17 fairly prominent athletes skipped the Rio Olympics, citing this as their reason for skipping, and no cases reported during that time period. Now, down here in Tampa, that's not quite the case. We have had cases here in Tampa. We have not had very many actually mosquito pools test positive in Tampa. But we've had individuals, either travel and come back or non-travel and test positive. This is just a CDC graph showing or figure showing the Miami area and the 3 neighborhoods that were affected and considered, hot zones essentially for Zika. All of those have been cleared now for over 45 days, but we continue to monitor. We don't test routinely for Zika. We have some parameters that we'll send to the Department of Health for, and we did consider using rapid routine testing for specific parameters in the ED. However, we essentially pulled that when these cases sort of ended, and it's been 45 days, or over 45 days since we've seen one of those cases. But at the time, we had considered a pregnant female with travel would be treated, would be tested, or a male with travel who had rash, rash and fever. We would consider testing as well, but never quite came to fruition, fortunately. And we'll see if this rolls off and kind of goes away to the land of SARS and Ebola and rapid emerging infectious diseases of yonder, or if it kind of becomes endemic or smolders in the background. We are pursuing a number of different research opportunities related to Zika. There's vaccine grant applications out. There are just different sort of public perception quality survey type of grants out or projects that are ongoing. Our toxicologist and director of poison control here in Florida, Dr. Tom Parody, was actually tasked with taking a lot of these calls from the public regarding Zika. We're looking at some of that data that was obtained from those patients or public individuals who called in. Not a gigantic blockbuster year for actual medical innovation in the emergency department, but a few interesting studies. I think the pendulum for MRSA in community-acquired abscesses and the pendulum for antibiotic treatment for community-acquired abscesses continues to swing back and forth and back and forth and back and forth. And the debate over what do you do with an abscess and what do you do with cellulitis, superficial skin cellulitis, continues and rages on. Whether it be antibiotics or antibiotics, irrigate, no irrigate, elliptical versus straight versus loop, or all these different debates. I think at the end of the day, there's probably different abscesses that need different things, and it may be hard to lump them all together. But overall, I think that Talon's paper here, basically showing that Bactrim probably should still be used for the majority of our skin abscesses that we're seeing is a good paper. We had some antibiotic stewards who were thinking that maybe we were overusing this at our hospital. I think most of us who work in a busy urban community community or tertiary care ER probably recognize that there's a reasonable amount of sick MRSA type patients out there, potentially sick MRSA type patients out there, and feel more comfortable using some type of antibiotic treatment. And I think the patients obviously prefer some antibiotic treatment, or at least a prescription for the antibiotics. So it's nice to have some data showing that those patients do have a faster cure rate. One of the coolest things about 2015 was when somebody I know well from Doctors for America, well, not well, I don't, somebody I do know from Doctors for America, Dr. Vivek Murthy, was tapped by by President Obama to lead as the Surgeon General. I think it's also very cool that Dr. Murthy was able to do something different than Surgeon Generals have done recently. I don't think this is as landmark as maybe tobacco use was, but I think in the context of the CDC opioid prescribing guidelines, in the context of HHS, in the context of the public sort of recognition of the opioid epidemic, I think that Dr. Murthy's paper here is exciting and interesting, and is certainly creating a lot of practice change, media, and paradigm shift. The only, I guess, two things with this is that one, how many of us would even be employed if it wasn't for alcohol, drugs, and maybe a little bit of anxiety and trauma in there, right? And how much trauma would there be without alcohol and drugs? So, it's interesting how much these social determinants of healthcare, especially in an acute care setting, an emergency setting, really generate our patients and our business and our job revenue. So it's an important paper about exactly the kind of things that we see as risk factors. I guess some cholesterol is important too, and some genetic stuff is important too. But man, right, these are really the things we see every shift. How many of your patients didn't have mental health issues if you're in urban ER last night, if you worked, or aren't alcoholics, or don't have some drugs on board? So I think this echoes well with us as ER docs. And fits nicely in the framework of what we're looking at right now with the opioid epidemic and those numbers. These are just some recent numbers from HHS about where the hotspots are and kind of some of the impact of spending and the impact on actual patients and numbers of patients who die. It's surpassing gunshots wounds now, and getting up there with traumas. So this is a still an important epidemic. I think what we have to be very careful of is that not all patients are the same, and that there are some patients with acute care who certainly will benefit from an opioid medication, and that 12 opioids for a true acute pain patient is not going to cause the low-hanging fruit, at least, of these addicts and dependents. So that's probably not the low-hanging fruit we want to go after. Doesn't mean none of those people become addicted, but that's, if they've got acute pain, not chronic pain, is that the first battle we want to fight versus the battle of the chronic pain patient, or maybe the musculoskeletal, probably overuse type injury that's not going to just magically get better with some opioid medications. But if we're not going to use opioids, we have to have something else, and we have to have the responsibility of learning something else. So we can't just say, I'm going to draw a line here, I'm going to fight you about opioids, I'm not going to use it. I think the thing we have to do is start to really, as doctors, as ER doctors, take a responsibility of learning other modalities. One of my residents right now is designing a study that is looking at using a specific type of exercise modality for some chronic back pain patients, really looking at the communication of the healthcare team and looking at just getting those folks involved in a movement and to a gym and those types of activities, and just seeing if that changes things more so than the exercise itself. Just doing the things and being out and having that communication and having a plan, does that change some of their outcomes at a year? So I think that's an example. I think learning some injections and blocks, and getting relationships with pain management folks, whether they provide benefit in this overall opioid epidemic picture, I'm not sure. But right, we need tools, and I think relationships and conversations, at least with those folks, is important. Or maybe it's encouraging our residents to go into a pain management fellowship that's important right now. But we have to have this conversation and arm ourselves with something more than no. One of the things I really struggle with in organized medicine is the issue of out-of-network balance billing. The the issue here is that essentially if a patient comes in to see us, they're out of network, how do we bill them to get paid a usual and customary care rate? We have to have the ability to out-of-network bill. This is something where I think the insurance companies have done an amazing job of pitting us against patients in an unfair way. Because I think it's a no-win situation for us if we go out right now and say we really want to balance bill and try to get the public behind us, or use our national organizations to have this as a major, advocacy point. Because then the public looks at those organizations and says, well, those doctors are just in it for the money. So I think we have to be very careful here and come up with a different strategy of probably really going after the insurance companies and having that conversation or argument with those folks and not the consumer advocacy groups. But Zach Cooper here and Fiona Morton were both consultants for insurance companies, and this study from the New England Journal, it was disclosed that these are folks who work quite closely with the insurance companies, and here in this study they really target emergency medicine as like the culprit of balance billing without really any discussion on solutions. So it's a complicated matter, and I don't know what the solution is, but I don't think it's walking to the bait, which I think they've set for us, which is a trap of fighting patients, consumer advocacy groups. This is the response from ACEP to that study, and again, I got to be careful here because I think there's bait on the table, and I just don't want us to take it. hospitals are busy and ERs are busy, and Florida's a busy, populous state. We had an increase of 3 residency programs this year, and that seemed like a lot at first. But then you kind of look at this list, and you realize we had just a hand. When I trained, there were 3 residency programs total in Florida, and you look at this list and of these 50 places, the top hospitals, the top busiest hospitals in the country, are 1 and 2 in Florida. And then on this list, there's probably 5 or 6 other hospitals in this top 50 in the entire country that are here in Florida, which is a population of I think about 20 million people, still with underrepresentation in the number of residency programs and training that we do have. So this is probably well tagged with the increase of residency programs, but it's just a busy place and it just keeps on getting busier. One. So, hypothermia has been kind of a hot topic, I think, for the past 3 or 4 years. There was the articles that came out in 2011, 2012, really, I think, moving us back to using more targeted or using therapeutic hypothermia. And then the New England Journal paper in 2014 on targeted temperature management, which I think some people misinterpreted as a negative study, saying there was really no role for targeted or for therapeutic hypothermia. I looked at it as really saying, I think there's actually a role for avoiding fever in these patients. The patients who were kept under fever are the patients who did well. It just wasn't that keeping them even cooler, they didn't do any better. So I don't think we should throw the baby out with the bathwater on this. I think there's probably a subset of this population who will do better after they are cooled. Now, another major thing that's going on in terms of changes in healthcare, and something we're seeing at Tampa General especially, and I think probably everywhere, are the use of teleservices in some way or another. The 2 major ways we're seeing this, we have moved towards having a virtual ICU, so keeping the exact same staffing we have medical staff-wise, keeping our residents, in-house, and, keeping our intensivists around, but also having on top of that a monitored ICU by an off-site intensivist, using technology. I think this is a big leap, jump for our hospital to begin testing this out, and it's something that's being seen in other places as well. And then I think the other piece of telemedicine that we're seeing now is the use of telehealth in our clinics, and having our patients have the ability to call in and use a telehealth software program to access our community physicians. Not doing it from the ER yet, and we really don't use it in our ER because we're a place that's a big academic center that essentially has every specialist available. Paramedicine sort of piggybacks on some of the tele stuff in terms of just accessing harder to reach places outside of the urban area, or within the urban area, really trying to get at those people who might be possible bounce backs or readmissions and seeing if there's a way to avoid it. I've learned from my EMS colleagues that paramedicine is a really controversial topic, and I think rightfully so. What the role is of these folks, I think, is still very unclear and nebulous and variable, and whether or not this actually translates to meaningful change and value add, I think, is also still on the table. So I think something we're going to continue to see talked about and probably tested more and more in more markets. Well, without SGR, I don't know what we're all going to do together anymore, because I felt like SGR was like our thing we could always count on every year, that when we got those emails from AMA or ACEP or whoever locally, hey, call your congressman, sign this petition, doctor, that we could all kind of come together and do. And so for those of you who don't remember, SGR, of course, is a sustainable growth rate formula, and it was part of the 1996 Balanced Bill Act that basically said Medicare payment increases cannot overtrack the overall consumer spending increases. And so in the late 90s, that was great because everything was going up, 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 up. And so, Medicare payments went up, 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 up. The problem is that in the 2000s, things started to go down, 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 down. And so essentially, there should have been Medicare cuts each of those years. And Medicare cuts to a short-term thinker like a politician don't sound very sexy. When people like doctors vote and give money and might or might not be influential. So, and patients even don't like to sound that, oh, my doctor might not take less, but my doctor might take less Medicare patients because the reimbursement rates are getting cut. So essentially, that SGR cut was withheld every year. And the owed money to the federal government for that cut, if it were to go through, was in the billions of dollars. So something had to be done to kind of either just take that money off the table, pay that money back, come up with a solution. And MACRA's been the solution. And I think, don't be fooled here. There's no doubt that the MACRA engineers certainly believe that that money will be returned to the federal government over time, essentially by cutting your pay through merit incentives and through quality incentives. So there's a couple forms of MACRA. There's an alternative payment model, which eventually, I think in 10 years, will be what MACRA mostly is. But right now, it's essentially a set of metrics that are quality-based that you'll be tied to. If you see, if you have a practice that's reasonable size, I think over 10 people, and if you bill over $30,000 in Medicare. So the vast majority of us will be subjected to MACRA, and so you want to make sure your group has a good handle on this, and that your billing folks have a good handle on this, and that you've got plans to address how to ensure that you don't lose as much money anyway as you might with MACRA. 21st Century Cures bill was a feel-good bill. Good stuff here. Basically, some of the opioid epidemic stuff is in this bill and was really driven by the death of Vice President Biden's son from a cancer, and was talked about in President Obama's last State of the Union address. And so that bill did pass, and I think there's some good money in here for NIH funding for different research opportunities. Obviously, Donald Trump won the election in November, and with that comes a very obvious public fight about Obamacare again and whether or not it'll be repealed, which is, as I'm talking about this right now, in the works with some obstacles. It wasn't quite clear when the election was over if that would still be the focus of, or a focus of the presidency. But I think the selection of the HHS secretary made it pretty clear that's where we were probably heading with Tom Price. Now, what Seema Verma brings to the table, I think, has been a little less clear, but most people speculate, given her prior work on private Medicaid expansion, this probably means there'll be some support within HHS and for Seema Verma to use CMS to kind of think about how states may use a more private Medicaid expansion type model like Indiana utilized. And then, of course, Tom Price, who's been a big resistor opponent of Obamacare, from the beginning, is now the HHS secretary. So there will be changes, whether that's a full repeal, piece repeal. I think that's still a bit unclear. Have you heard of a carotid artery web? I have never heard of a carotid artery web until this, and I find it kind of fascinating. So we see a lot of young people at our place who have essentially cryptogenic strokes, not clear why they had a stroke. We count a lot of this to drug use, especially with spice. We do have some definite cases where the patient used spice and had a stroke with no coronary disease risk factors under the age of 30, under the age of 40. This carotid web study that came out in the Journal of Neurology, I think, is interesting. Essentially, a large number of patients who had no real risk factors for stroke and ended up having a cryptogenic stroke. On further analysis, further study, also have these odd little carotid webs. So they essentially have a carotid stenosis. So, I think this may explain some of the occult strokes that we do see that don't fit the ABCD score and, other risk stratification tools. TPA has been 20 years now, 20 years of debate about TPA in emergency medicine. I will just say this, obviously the studies that were published were controversial, and the studies that weren't published are even more controversial, and the studies that were published with negative effect are very controversial. And so I understand that in 1996, 1997, ER docs had some consternation about using a drug that can make you bleed. Having said that, though, the bleeds we see, we use a lot of TPA, and we are a big stroke center. We have a stroke registry for Florida and for Puerto Rico housed at our place. The number of bleeds we see is much, much lower. We have, I think, pretty good selection of the patients we put in, right? Younger patients who are closer to stroke, are the ones who tend to do better, it seems like. So I think we see much lower rates of bleeding, certainly not 10%, probably not even 3%. I think it's all a selection of our patients. Now, having said that, Stroke issued new guidelines this year, which are very aggressive to using TPA. And they're aggressive in people who I think for a long time we talked ourselves out of using TPA in. So, for example, the conversion disorder, the improving stroke, the patient who's got improving symptoms, improving NIH stroke scale score, or even a low NIH stroke scale score. I think in the past, a lot of us would talk ourselves out of using TPA for those patients. But I think in a logical sort of walk down of the argument, the stroke guidelines really advocate that these are reasonable patients to use TPA in because they're not patients who are sick. And so the risk is not zero of a bleed, but the risk is lower of a bleed than a patient who may actually truly be having a stroke and need TPA. So overall, if you look at risk to harm to the population, these patients who present, the argument is that you're going to help a lot more people than you're going to hurt. And if you're young and healthy, you're not actually having a stroke, and you take TPA, the vast majority of those patients won't bleed. So I understand there's probably some consternation about that itself, but I was putting it out there because that is the guidelines now. So I think we're still at full dose TPA though. This low dose TPA study was an Asian subset population with a recognition that they do tend to have some more bleeds at the high dose. Did not quite reach non-inferiority though, and so I don't think we can move towards anything but the standard, 10%, 90% dosing of TPA at this point. This is a study that I have been involved in thinking about and talking about, and it's disappointing to see the results, and it's disappointing, I think, for a lot of people who worked really hard hoping for better results for this study in the Socrates trial with ticagrelor versus aspirin to treat acute stroke or TIA. So essentially, and unfortunately, post-stroke patients on ticagrelor didn't really have any better outcomes than patients who just took an aspirin. So I think this is a bit of a blow to AstraZeneca and potentially to the brand name Brilinta, the drug. I don't know what's going to happen to that drug in the market. So it's obviously not penetrating that highly with, at least at our site, and I think a lot of sites, it's not penetrating as highly as maybe people would have expected after Pegasus. With the acute coronary syndrome patients, the patients going for a STEMI or NSTEMI. So this is another avenue for that medication, which is not going to pan out. So here's a study that made a lot of news, and a study that has been all over the message boards, and a study that is probably overblown from where it actually is, and it's probably not quite as big of a deal as maybe people have made it out to be, and what's become like these, essentially sexist battles on Facebook, on the message boards. But this is the comparison of hospital mortality and readmission rates for Medicare patients treated by male versus female physicians. So in other words, this is just hospitalists, and this is just Medicare patients. These are elderly patients treated by hospitalists. And a number of variables that are in here, outcome measures are in here, the readmission rates and the mortality rates were lower for the patients treated by females than for males. Not by a gigantic margin, but they were statistically significant. I have no idea what to make out of that. Does it mean females better doctors? Does it mean more hospitalists have better female doctors who are good at coordinating care at 30 days? Well, I don't know. I don't know the answer. I think it's a limited ability to interpret from this study, given the narrow patient population, given the narrow question that was asked, given the question was asked is a tautological answer in the sense that this thing happened, but doesn't explain a why, and I don't know if sex is a variable for that explanation or not. So anyway, it's interesting because it's making news, and you'll hear about it. I just don't know what to make of it in terms of how it would change anything in terms of practice. A number of drugs I think took a hit this year from the FDA, and probably going to make our practice a little bit more difficult. Codeine I think took a good hit. Codeine causes a lot of histamine reactions, and it's a sloppy drug, and really is now by the FDA, not considered a good first line treatment for pain in pediatric patients. I think that's great. Fluoroquinolones also should no longer be considered first line drugs. This is going to kill our urology department that puts essentially anybody with a ureter on Cipro, who's ever made urine before. They all get some Cipro. So I don't know what they're going to do because the water's not free anymore. And I think it makes it really difficult for us, though, in the ED when we have elderly patients, who we don't want to use macrobid on for creatinine clearance reasons and absorption, all those kind of reasons about elderly people and nitrofurantoin, or patients with pyelo, things like that. I think it just takes another quill out of our arrow set. So it's just another drug that took a hit, and it's a little bit difficult. Kind of cool. This is kind of like when those old people come in and they've been married for 50 years, and maybe the wife dies on Tuesday, and then Thursday, right, the husband dies. Kind of the same thing in a nice way here. Dr. Heimlich, who of course invented the Heimlich maneuver, used the Heimlich maneuver for the first time just recently, back in the spring, May 27th, back in the late spring, early summer, and then just recently, a couple weeks or a month ago, passed away himself. And so kind of a nice story. Lived a good life, 96 years old, and contributed to the world and had a nice life, it sounds like. This was a retrospective review of a lot of different ways that hypothermia was done and a lot of variation in those ways. So I just want to put that out there. This is not a prospective study with a strict protocol, right? This is people who came into the study in multiple ways. So I think this has to be understood with that, with that knowledge. Traumatic brain injury, hypothermia was looked at for that set of population, and did not seem to have any positive effect. And then I think for our own specialty, if you're an ER doctor, one of the cool things to watch has been the evolution of the EM Docs Facebook page. Now, I will say that the biggest lesson that the EM Docs Facebook page has taught me is that the smartest people, any group of people, if you put them on the internet for 5 minutes, it devolves into a trolling war at an unbelievably quick rate. And there is no difference if you put a bunch of well-trained 9,742 ER doctors on that, on a message board, and if you put, a bunch of dudes, out by the truck stop on the message board or whatever, right? I mean, this is amazing how quick this devolves into name calling and pretty bitter, arguments that probably we would not have with each other in real life. So, other than that, it's been a pretty cool group to watch grow because this is the kind of group that you can have a case at midnight in an ER shift, a night shift, a real-time case, and you can go on this message board and you can post to other ER doctors, hey, here's what I have. Hey, here's a picture the patient let me post. I need some help here. What do you think? And you'll have 40 responses within 15 minutes or so. It's pretty amazing. Kay Moody runs this group, and you have to actually submit your hospital ID, and then someone in the group usually needs to vouch for you to kind of say, yep, this is a real ER doctor, you're in our tribe. And you come in the tribe, and it's a pretty cool experience. And just to give you an idea, this is just the people I know that are mutual friends of me and are in that group. And so, it's a group that's got real people in it, and there are community and there are people. And so, if you're on that group, I just kind of want to remind you too, these are our people, right? I mean, at the end of the day, it's really hard for any of us, politics and everything else aside, I think it's really hard for any of us to relate to people better, or in the same way at least, that relate to ER doctors, other ER doctors, given what we see, know, do, think, feel, and choose in life. So keep that in mind. We're all in the same tribe here. then, we fix one problem, right? We start to kind of get our head around how we're going to deal with spice and bath salts out there on the streets in Florida. But don't you worry, there's a new opioid hitting the streets, and this is coming right at the heels of fentanyl taking a lot of press and a lot of heat for probably some really nefarious business practices in terms of how to market that drug that led to likely some deaths. Now carfentanil is hitting the streets as well and being used recreationally. One thing of interest to me, because I do have an interest in sports medicine, is AMSSM revised their policies on who should get pre-participation sports screening. I think we think a lot about sudden death and cardiac relationship to sudden death. Overall, it's interesting. Not as many people in this study of watching these kids who had sudden cardiac deaths were actually definitively tied to a cardiac cause. And overall, if we would have, the vast majority had a genetic disorder if they did die. Now, of course, we have no idea how to recognize who needs to be tested for that or not, for the genetics or not. And going back to the MSSM statement, it's right now it's still controversial who even needs an EKG. I do think one of the best comments that have come out of this past year in the creation of the guideline statements by MSSM or the revised statements has been this concept of, if anything, we do these pre-participation physicals, an EKG is probably more meaningful than the physical exam itself. But I think the overall take on this is that there's probably a subset of patients who need a EKG more than anything else, and if that EKG is abnormal, perhaps they need other testing. Maybe it's this genetic testing where these patients were found retroactively to have genetic disorders that would have been picked up if they were genetically tested. Just have no idea who to test. So who should get tested for EKGs? If you look at college basketball players, high school basketball players, right, there's definitely, well, especially college basketball players, definitely a much higher rate of incidents and events. So maybe it's the sport you're playing. Maybe it's the, population you're from. So I think this is on the table, but the recommendation of AMSSM is to consider EKG in the right population of patients, but not to demand that or to leave doctors on the hook of saying that's something that has to be done, recognizing that screening everyone who walks in the door is probably not going to be that beneficial. Having said that, what does it hurt? Are there downstream effects of these EKGs? I think that's still the question on the table, unfortunately. A study I've taken part in and thought a lot about as one of the ANEXA investigators is the ANEXA for acute major bleeding associated with factor Xa inhibitors trial. This is still ongoing. No offense, Portola, if you hear this, people I respect there, but I think the company got their ass handed to them by the FDA, and I think this happened because they weren't ready when they went to the FDA to ask for approval. The problems were that there was not enough patients in study yet. There were not enough patients with head bleeds. There were not enough patients with enoxaparin in the study. And I think right now, and there's no patients with traumas or surgeries, and there's also patients who do not get other products. So there's no use of Kcentra on top of this, just blood products and platelets. And so I'm not surprised that Anexa, which is essentially what you call, I guess, a reversal agent, right, for your factor Xa inhibitors. It's like rivaroxaban, apixaban, petrexaban. So, it would be a reversal agent for that. I think it works. I think the drug works. I think the FDA knows the drug works, but the data and the way the study was designed has some limitations. So what we're going to see is the study continue, and then eventually we'll see a trauma and a surgical arm. And then I think after that is completed, then you go back to the FDA and maybe you ask for indication at that point. One of the things I think we have to remember as ER doctors, and maybe a little bit surprising here, is that the number of patients who do present with syncope, probably more of those patients have a PE than we originally thought. Now, granted, this is the PESIT study is a study of older patients, maybe we're used to, and also patient population in another country. But having said that, 1 out of 6 of these patients who presented with syncope, P was the diagnosis. So just something to remember when you've got your syncope patient in front of you and you're working them up, you see some right heart rate on the EKG, maybe you see a little right bundle branch block, something's not quite normal, maybe move on and just make sure that they don't have, evidence of PE. Whether it's by history, physical exam, or diagnostic testing. We talked about the pre-participation physicals, so I'll leave that one alone. And then I'll end things on probably one of the saddest notes of, well, really one of the saddest notes of my career, and one of the most devastating blows to my career. David Newman's demise from emergency medicine and from, well, from life, really, occurred this past year, just the beginning of last January. Dr. Newman was accused of essentially sexually molesting a patient in the ED. If you don't know, Dr. Newman was a well-respected physician. Spoke at Essentials, was on MRAP, had a blog, Number Needed to Treat. Young, 45 years old. Kids, wife. Young wife. Really just active, smart guy with an active, smart wife with young kids. Just dynamic couple, smart people, contributing tons to emergency medicine. And when this came out, I hoped that this was a crazy patient, right, accusing him of something. But the problem, quickly became obvious that why A would, law enforcement listen to the crazy patient, right? And B, now we've got 2 crazy patients, 3 crazy patients, up to 3 now. Okay, and then a couple weeks later, we go from the New York Post to the New York Times. Now it starts to look a little bit more concerning. And then I remember looking at that first appearance of David Newman when he leaves his house to go to the courthouse, and he doesn't look defiant. He doesn't look like he's gonna go and say, "These people are crazy. What's going on? This is insane. I'll get my reputation back. This is slander." No, he looks dejected and he looks sad, and he looks guilty. And so a couple weeks after that, we hear his first sort of the first details of the case. And it turns out that basically this woman who accused him of molesting her says that he gave her a dose of something. She thinks it's a pain medicine. And she was incapacitated, and that she saved a towel that had ejaculate on it from him. And so his excuse isn't, or his response isn't, "That's insane." His response is, "Oh, well, I might have been in the break room, and I might have been doing my business in there, and I might have come out a little too soon, maybe not washed off well." That is not a very promising or reassuring answer. So, it turns out she kept this towel that she wiped herself off with and took it to the police, and there was DNA, and they went to his house with the DNA. I don't know if it was the next day or a couple days later, and they went to the hospital and told them about the DNA, and so it was pretty clear they had a pretty good case building against him, and it was propofol, which is amazing to a lot of us that he was able to get this drug and walk into a room with it on his own, that it wasn't the Pyxis or Acudose or whatever. But remember, it's not a controlled drug, right? And morphine is, so it's probably easier to actually get this, technically speaking, than it is morphine. So I don't know how he got it or what happened there, but he that's what he used. And basically these 3 patients are the ones who've come forward, which in my mind that means this is the tip of the iceberg. There's probably a whole bunch of patients who have no idea this happened to them because they're on so much propofol. And there's also another group of patients who are just not going to want to deal with this in their life and are not going to come forward. But either way, obviously his life is pretty much destroyed at this point, and his career is destroyed. And I think it's a bad look for us in emergency medicine. Fortunately, it's not getting a huge amount of press, which is a good thing. So I don't know how much more pessimistic I could be than that last note, but that's not my goal. I mean, my goal is really just to recap 2016. Actually, I love what I do. I love emergency medicine. I wouldn't do anything else, and I enjoy this. I enjoy doing what I do. I just want to be realistic, because I think, if anything, I'm optimistic quite often. I think sitting here and making myself kind of go through these things, see some of the reality here, it just leaves a realism on the table that's important for us all. But yeah, love what you do. It's fun. It's good stuff. We're helping people. And, I think the thing to remember again is be a part of something bigger than yourself. So thanks for listening, and I hope this was useful.